Good afternoon, everyone. I'm going to present myself on ischemic optic neuropathy, giant cell arteritis, also known as temporal arteritis. Giant cell arteritis is the most common primary vasculitis in adults, involving medium and large size vessels in elderly age. It is considered a medical emergency due to its potential to cause permanent vision loss due to GCA, is arthritic anterior ischemic optic neuropathy. I'm going to present myself on GCA. Like I'm going to present two cases of GCA. First one being a 62-year-old non-diabetic and non-hypertensive male who came with the chief complaints of sudden painless decrease in vision left eye since 3 months. Previously, he was diagnosed as optic neuritis left eye, treated with IV methylpred for 3 days and was followed by oral steroids for 2.5 months in tapering doses, which he stopped a week prior to the presentation. The general examination was normal within normal limits. On examination, the visual acuity in left eye was counting finger at 1 feet. There was RAPD in left eye. Motility was normal in both the eyes. Left eye fundus showed pallid disc edema. On local examination, the superficial temporal artery over the left side on palpation was hard, tender, and cord-like non-pulsatile. Previous investigations were normal, except the CRP was 11.5 milligram per deciliter. On repeat investigation, the CRP and ESR were quite raised. So, which led us to the diagnosis of AION, left eye due to occult GCA. Biopsy was done on the next day and was restarted on IV methylpred for 5 days, followed by oral steroids, 1 milligram per kg body weight, and tapering doses. We took the superficial temporal artery biopsy. First, we palpated it, and LA 2% was given. And with the caliper, 3 centimeter of artery was measured and dissected. And it was sent for histopath, where the findings of superficial temporal artery demonstrated presence of chronic inflammatory infiltrates in the adventitial and medial layers, accompanied by arterial wall calcification. Coming to the case number 2, which was about a 58-year-old non-diabetic, non-hypertensive female who came with the chief complaints of sudden painless loss of vision in right eye for last 3 weeks. Patient also gave history of pain in the jaw while eating and generalized body ache more in the neck and shoulder area 2 weeks prior to the visual loss. She visited to a local ophthalmologist, and the medical records show her vision to be PL positive with RAPD right eye. Disc edema with pallor and superficial hemorrhages were reported on the fundus examination, but no proper diagnosis was noted in the records. General physical examination was within normal limits, and superficial temporal artery pulsation were feeble but non-tender, and it was not hard. On ophthalmic examination, the visual acuity in right eye was PL negative. In left eye, it was 6/12 with pinhole improving to 6/6 part. Ocular motility was full in all the gazes. There was RAPD in right eye, and in right eye fundus, there was pallid disc edema with superficial hemorrhage. Previous investigations were normal. The ESR was 94 millimeters per hour, and CRP was not asked by the doctor. Rest investigations were normal, including the neuroimaging. On repeat investigation, we found the ESR and CRP both were raised. So we made a diagnosis of AIN due to GCA with systemic symptoms. For management, we sent the patient for USG of superficial temporal arteritis, which showed doubtful halo sign, and patient was planned for vessel wall MRI. Oral steroids were given, and they were increased to a dose of 60 milligrams as CRP levels were still on the higher side. Result, in case 1, based on the above mentioned history, clinical examination findings, and blood investigation results, we made a diagnosis of occult GCA without any systemic association. And in second, there was GCA with systemic symptoms. In conclusion, GCA is supposed to be rare in Indian scenario and often underdiagnosed. Early diagnosis and management is required to prevent the irreversible visual loss in these cases in the fellow eye. Discussion. GCA is most common primary vasculitis in adults, most commonly seen in above 50 years. Women are commonly involved than men, approx 2 to 6 times, and its most common feared sequelae of GCA is permanent visual loss, secondary to AION, and it is considered to be an ophthalmic emergency since the AION can progress rapidly and involve the fellow eye within a matter of days. When GCA is suspected, treatment with corticosteroids is indicated on urgent basis. This is the classification given by American College of Rheumatology in 2022 to classify GSA, where a score of more than or equal to 6 is needed to classify giant cell arteritis, where the absolute requirement is more than 50 years old, and other things we can see. Thank you.
What was the ESR in both of these patients? In the second patient, when you repeated, it was 29. The ESR, yeah, ESR. And in the first patient?
I mean, in first patient, it was 80 something around,
okay.
More than 50.
Yeah, generally because the ESR has to be above 50 to get the diagnosis. And what was the treatment for the follow-up period? What have you put the patient on?
Mainly, first we put the patient on IV steroids for 3 days, and then we shifted the patient on oral steroids and tapering doses.
Okay. So after your steroid is withdrawn,
yes,
what will you do to prevent the GCA in the other eye?
Ma'am, steroids are given to prevent
so have you given, ideally the whole thing about doing a temporal artery biopsy is to prove that it is a GCA, so that the patient can be put on a very long-term steroid.
Yes, ma'am.
What is the percentage of involvement of second eye in AION? How much percentage is the risk for the second eye involvement?
Ma'am, 60 to 70% around. It involves the, ma'am, within 1 week it involves the other eye usually.
Okay.
What are the other life-threatening conditions in such patients? We can assume there may be other patient may develop other signs and symptoms. What are the other, some are life-threatening.
So other signs and symptoms.
No. Other structures also may involvement, not only the temporal artery. It may be fatal for the patient. So what you will do in
so
your
further complications can be
is not a complication, is a sequelae of that.
So it can further lead to the vision loss in the other eye and
that's one. I mentioned this fellow by chances is high. Okay. Any other which may be life threatening? That step 2 in the
so if it involves
management.
other
Pardon?
arteries, then sir it can lead to stroke and MI and
yes.
scalp tenderness.
Always is a mandatory to take your opinion of immunologist and cardiologist.
Yes, sir.
So is the rheumatologist or immunologist. Better term is nowadays immunologist or rheumatologist proper. Not only just with a 1-year training of the rheumatology and the proper cardiologist.
So along with that, we have to give immunosuppressants also.
Always, yes. we take the term is critical care. Under the patient should be under critical care team who knows all. Good presentation.